Small airway disease. The learning objectives of this lecture include define terminology and classification of small airway disease or bronchiolitis, review common disease entities manifesting as bronchiolar disease, and describe clinical and imaging clues helpful in narrowing the differential diagnosis. Small airways refer to both membranous and respiratory bronchiole. In addition to the small size, they are distinguished by lack of cartilage and submucosal glands. Small airways are arranged within the secondary pulmonary lobule, branching from a central lobular bronchiole that in turn supplies 3 to 12 terminal bronchiole, respiratory bronchiole, and alveolar ducts. The functional zones include the terminal bronchiole are mainly a conducting zone. The respiratory bronchiole are a transitional zone with both conducting and respiratory functions. And the alveolar ducts and sacs are mainly a respiratory zone. When we talk about bronchi and bronchioles, they're usually not normally visible in CT due to the small size. Bronchioles are rarely visible within 1 centimeter of the pleural space. When they become visible in CT are when we have some kind of pathology, either inflammatory bronchiolitis or cellular bronchiolitis, as we can see in this CT, where we can see mainly small centrilobular nodules and tree-in-bud pattern located in the center of the secondary pulmonary lobule with sparing of the subpleural space, and we can also see an area of consolidation in a patient with pulmonary TB, or in patients where we can see constrictive bronchiolitis or fibrotic disease. And in this CT we see areas of normal lung, that are these areas of hyperdense, and areas of air trapping with diminished vascularity in a patient with constrictive bronchiolitis. Small airway disease or bronchiolitis, as a definition, include inflammation or fibrosis of bronchiole, usually centered in and around of the membranous and respiratory bronchiole. High-resolution CT may show direct and indirect signs. Direct signs include bronchiolar wall thickening, bronchiectasis, luminal bronchiolar impaction, including both centrilobular nodules and tree-in-bud pattern. Indirect signs include mosaic attenuation pattern in inspiratory CTs and air trapping on expiratory CT. I'm going to show some examples of direct signs. Here we have a coronal and an axial view of a patient with Kartagener syndrome, where we can find bronchiolar wall thickening and some small centrilobular nodules and some mucus impaction. We can also notice in the left lower lobe areas of air trapping with diminished vascularity. Bronchiectasis may also be seen, as in this case, in the both lower lobes, where we can see bronchiectasis and bronchiolectasis with some mucus impaction and small centrilobular nodules, some of them with a tree-in-bud pattern. Notice the sparing of the subpleural space. Another example of bronchial and bronchiolar wall thickening with some small centrilobular nodules, and also notice the sparing of the subpleural space, and notice that the findings are usually centered in the middle of the secondary pulmonary lobule. If we have to define where's the centrilobular area, it's in the center of the secondary pulmonary lobule. We can see the terminal bronchiole, the respiratory bronchiole, the alveolar ducts and the alveolar sacs. Notice the sparing space in the subpleural area, and when we look at the CT we see small centrilobular nodules resemble tree-in-bed pattern and sparing of the subpleural space, as we can see in this graph on the upper part of the image. Direct signs may also include ground glass centrilobular nodules. This is an example of a patient with hypersensitivity pneumonitis, a patient exposed to pigeons, where you can see small ground glass centrilobular nodules with a diffuse distribution in a patient with small airway disease. Here we have another example where we can see a cavitary lesion on the right upper lobe, and in the right lower lobe we can see small nodules, centrilobular, solid, with tree-in-bed pattern in a patient with pulmonary TB. The tree-in-bed pattern usually shows secretion of mucus impaction on the alveolar ducts, alveolar sacs, and respiratory bronchiole. And when we look at the CT, we can find perfectly this mucus impaction with a tree-in-bed pattern in the center of this secondary pulmonary lobule. This is a sign of small airway disease, cellular bronchiolitis. Inflammation is usually the main cause of tree-in-bed pattern. As we mentioned before, and we're going to repeat it again, we can see the stalk, that's mainly the last order bronchos, and the tuft, that's mainly due to the bronchioles and the alveolar ducts. Here we have a patient with tree-in-bed pattern in the right upper lobe due to pulmonary TB. If we need to classify small airway disease, we can divide them into two categories. First one is cellular bronchiolitis, and the second one is obliterative or constrictive bronchiolitis. Cellular bronchiolitis include infectious, aspiration, respiratory bronchiolitis, usually associated to smoking, hypersensitivity pneumonitis, diffuse panbronchiolitis, and some causes that include bronchiectasis and cellular bronchiolitis, such as cystic fibrosis or Kartagener syndrome. Cellular bronchiolitis, as we mentioned before, in high-resolution CT, we can find direct signs that include centrilobular nodule and branching lines in a tree-in-bed pattern. Here we see mainly inflammation within the wall of the bronchiole and also in the lumen. And when we look at the CT, we see perfectly the centrilobular nodules resembling a tree-in-bed pattern. The main causes of infectious bronchiolitis include non-tuberculous mycobacteria. We need to look at centrilobular nodules and tree-in-bed opacities, mainly associated to bronchiectasis in the middle lobe and lingula. This is a patient with non-tuberculous mycobacteria that has small centrilobular nodules, some of them resembling a tree-in-bed pattern, associated to bronchiectasis in the lingula and in the middle lobe, in a woman of 60 years old. This is another patient that has in the right upper lobe cavitary lesions with thickened wall associated to small nodules, some of them resembling tree-in-bud pattern in both right and left upper lobes. And we can also see findings of cellular bronchiolitis in the in the upper segments of the lower lobes. Another case of pulmonary TB, we can see cavitary lesions in both the upper lobes and the upper segment of the lower lobe in association to small centrilobular nodules, some of them resembling a tree-in-bud pattern. Some viruses, such as adenovirus, also may show small centrilobular nodules or tree-in-bud pattern. Usually most of these cases of virus occur in young population, and these patients usually are mainly diagnosed by clinical approach and X-rays. Aspirative bronchiolitis is also an important cause of cellular bronchiolitis. Predisposing factors include chronic inflammatory reaction, esophageal disorders, neurologic defects, and chronic illness. High-resolution CT usually show centrilobular nodules, uni or bilateral tree-in-bud opacities, and we need to be very careful and check the dependent portions of the lung. In this patient we have esophageal dilatation, some centrilobular and paraseptal emphysema. We have a right upper nodule, and in the right lower lobe we see small nodules confluent in a patient with aspiratory bronchiolitis. Diffuse panbronchiolitis is an idiopathic disease that mainly is a sinobronchial syndrome. In the first stage of this disease, we can find mainly centrilobular nodules and tree-in-bud opacities as the one shown in the image seen. In this case, small centrilobular nodules in an Asian patient. And in the second stage, we can see progressive bronchiectasis and bronchiolectasis and decreased lung attenuation due to air trapping, as we can see in this CT. Air trapping with diminished vascularity in a patient with indirect signs of small airway disease. Cystic fibrosis is mainly due to chronic and recurrent respiratory infections. And we can see cylindrical bronchiectasis, usually predominant in the upper lobes, as we see in this patient. Bronchiectasis with mucus impaction and some small nodules, centrilobular, some of them resembling tree-in-bud pattern. We can also see bronchial wall thickening, mucus plugging, and as I mentioned before, tree-in-bud opacities. Another patient with cystic fibrosis, where we can notice mucus impaction, bronchiectasis, associated to small centrilobular nodules, some of them resembling tree-in-bud pattern, with areas of air trapping, and also notice the sparing of the subpleural space. Kartagener syndrome usually is associated to Situs inversus, sinusitis, and bronchiectasis. In this patient has dextrocardia. We can see bronchial wall thickening bronchiolar wall thickening, bronchiectasis and bronchiolectasis, and as we see in this patient in the right lower lobe, small centrilobular nodules resembling tree bed. Another important sign of cellular bronchiolitis, a direct sign, include centrilobular nodules. Here is a patient with hypersensitivity pneumonitis, subacute or non-fibrotic, that shows diffuse, poorly defined centrilobular ground glass opacities or nodules, and notice the sparing of the subpleural space. The main differential diagnosis is hypersensitivity pneumonitis and respiratory bronchiolitis. Hypersensitivity pneumonitis is an immunological disorder due to inhaled organic and inorganic antigens, and patients usually manifest with dyspnea, cough, and malaise. CT show centrilobular ground glass nodules, patchy or diffuse ground glass opacities, and expiratory air trapping. Notice that cysts can also be seen in patients with hypersensitivity pneumonitis. In this CT, we see small centrilobular ground glass opacities, and we see a cyst in the right upper lobe. Patient presenting with patchy areas of mosaic attenuation, with areas of ground glass opacities that are confluent, and areas of diminished attenuation. The patient had a history of 60 pigeons in her house, and when we performed the CT, we noticed that in the Expiratory CT, those patchy areas of ground glass opacities, when we look at them carefully, were small centrilobular nodules of ground glass opacities in a diffuse distribution. We perform expiratory CT and we see mainly areas of air trapping in both lungs in a patient with hypersensitivity pneumonitis. Respiratory bronchiolitis, usually associated with smokers, more than 30 pack years, and most of them present with restricted function. In patients smokers, we can see in the upper lobes small centrilobular ground glass opacities, some of them patchy or diffuse. We can also see in this patient small areas of emphysema in a patient with respiratory bronchiolitis associated to smoking. Another patient where we can see areas of ground glass opacities, mainly with a centrilobular distribution, some of them acquiring a more patchy distribution with an upper lobe predominance in a patient with respiratory bronchiolitis. Another patient where you can perfectly see the small centrilobular ground glass nodules with an upper lobe predominance in a patient also with paraseptal emphysema and smoker. We can also see areas of centrilobular emphysema in a patient with respiratory bronchiolitis. Follicular bronchiolitis is more unusual. This is a case courtesy of David Lynch. They usually are associated with Sjögren, rheumatoid arthritis, and immunodeficiency. High-resolution CT shows centrilobular and peribronchial nodules, and we can also see mild bronchiolar dilation and bronchiolar wall thickening. Cases can also be rare, as in this patient with a pure inhalation talcosis. There's usually accidental inhalation in children, and in adults was mainly due to cosmetical purposes. There's no risk of neoplasms, And in this patient, we can see small ground glass opacities with a centrilobular distribution, sparing of the subpleural space in a patient with pure inhalation talcosis. This is a case courtesy of Fernando Gutierrez. Indirect signs of bronchiolitis include mosaic attenuation in inspiratory CTs, where we can see areas of diminished attenuation and areas of higher attenuation, patchy. And when we perform the expiration of the expiratory CT, we can see mainly areas of air trapping with diminished vascularity due to vasoconstriction in a patient with hypersensitivity pneumonitis due to hot tub lung syndrome with non-tuberculous mycobacteria. Constrictive orbitary bronchiolitis main causes include infection, can either be viral, bacterial, mycoplasma, toxic fume inhalation, collagen vascular disorders, mainly rheumatoid arthritis, chronic lung transplant rejection, chronic graft versus host disease, and idiopathic causes. This is the first case of air trapping on expiratory CT due to post-smoke inhalation. What we can see in pathology is mainly fibrosis in the submucosal area of the small airway, reducing the lumen of the bronchiole and producing a valve mechanism where the air goes in the expiration and it gets trapped in the expiratory CT. This is a patient with mainly areas of air trapping with diminished vascularity, patchy areas of higher and lower attenuation, and a patient that was at a smoke inhalation fire. Same case, in inspiration, we can barely see areas of patchy attenuation or mosaic attenuation. And when we perform the expiratory CT, we see areas of air trapping and areas of normal lung in a patient with post-smoke inhalation. Swart-James-McLeod syndrome. It was usually described as a hyperlucent lung. And now when we start performing CTs, we can see that both lungs can have areas of air trapping. In this patient, we see an inspiratory CT where the right lung has mainly air trapping and diminished vascularity, and the right lung had air trapping and diminished vascularity, and the left lung has subtle areas of diminished attenuation. When we perform the expiratory CT, we see the right lung with areas of air trapping, and also in the left lung we see areas of normal lung and areas of air trapping with diminished vascularity. Infections, as we mentioned before, can also be a cause of obliterative or constrictive bronchiolitis. And this patient with RSV, we see inspiration with subtle areas of mosaic attenuation. And when we perform the expiration or expiratory CT, we see areas of air trapping and areas of normal lung in a patient with constrictive bronchiolitis. This is a very interesting case. It's a patient that had lung transplant, and the patient really knows her pathology. And when she performs functional test. She had an FIB1 reduced, so she goes and talks to the pulmonologist, and she is concerned about this finding. So CT was performed, and when we look at the inspiratory CT, we see areas of bronchiectasis with some consolidation surrounding the areas of bronchial dilation, and we can barely see areas of mosaic attenuation. When we perform the expiratory CT, there's mainly air trapping in both lungs due to chronic transplant rejection. This is the coronal view of the same case, where we can see the areas of air trapping in both lungs due to constrictive bronchiolitis. Rheumatoid arthritis, as we mentioned before, is another cause of obliterative bronchiolitis. Here's an inspiratory CT where we see areas of mosaic attenuation, normal lung, and areas of diminished attenuation. We perform the expiratory CT and we see perfectly the areas of air trapping in both lungs due to constrictive bronchiolitis. Another case of rheumatoid arthritis, we can see the first CT performed with areas of mosaic attenuation and some subpleural nodules. When the patient was treated, we see resolution of these subpleural nodules, and the expiratory CT shows perfectly areas of air trapping in a patient with rheumatoid arthritis. It's very important to mention that air trapping or bronchial disease can be the first finding in patients with rheumatoid arthritis. As a conclusion, high-resolution CT can be very useful in patients with bronchiolitis of small airway disease. When we talk or when we find tree-in-bud pattern, as we see in this CT in the right upper lobe, we need to think in two entities, infection and aspiration. When we see centrilobular nodules, especially poorly defined ground glass, there are two main differential diagnoses: hypersensitivity pneumonitis and respiratory bronchiolitis. One is mainly associated to smoking and with an upper lobe predominance, and hypersensitivity pneumonitis is associated to exposure to an antigen and is mainly more diffuse distribution. Mosaic attenuation and air trapping, mosaic attenuation in inspiratory CTs and air trapping on expiratory CTs, are mainly seen in patients with obliterative or constrictive bronchiolitis. We need to remember the main causes, as we mentioned before, like post-infection, post-smoke inhalation, post-transplant. Those are the main causes. And we can also see air trapping in patients with hypersensitivity pneumonitis, both in the non-fibrotic and fibrotic stage.